Okay, good afternoon, everybody. I hope you can hear me in the back. Probably don't actually need the microphone. So it's been a long day of sitting in hard, uncomfortable chairs, listening to important and exciting lectures, but still, it's hard to keep attentive to didactic stuff all day. So we're at the point of the program where we're supposed to have some intimate and interactive discussion about cases, and the title is How I Do It, but it's meant to be a discussion about how we might do it. So I don't have that many slides, and it's more about questions. So feel free to interrupt, and I'm going to ask you questions, and you can ask me some as we go along. So refractory hypoxemia, but rather than restrict ourselves to a very strict definition of a refractory hypoxemia, let's just talk about sort of a challenge, the challenging to oxygenate patients, right? The truth is that most patients are pretty easy to oxygenate. After you get a tube in and a little bit of PEEP, most of them are okay without a whole lot of effort on our behalf, right? But there's a significant minority, maybe 10, 15% of patients who really are challenged to oxygenate, and that's where our skills as intensivists and ventilator jockeys come into play, right? I remember working with when I did my first rotation in the ICU at the Wellesley Hospital, which doesn't exist anymore. It's not condos. That tells you how long ago that was. Tom Stewart was the director there, and he told us as residents, okay, here's the thing, here's the deal. Nobody dies of hypoxemia in our unit. Patients they'll die of other things, but they're not dying of refractory hypoxemia. And that's sort of of course that wasn't completely true, but that was the kind of the attitude that we had. And I think it's useful to have that mantra, especially now in the days of ECMO, we can actually make that reality come true. So let's start with a case. Here's a woman who's been intubated and ventilated for a couple of days for pneumonia. She's initially, you see her on pressure controlled ventilation with a pretty high driving pressure of 20. PEEP is 12, and she's getting just over 6 mils per kilogram tidal volumes by predicted body weight. So 90% oxygen, and the PO2 is 82. So in order to help you decide what to do next here, a diagnostic test was performed. What more information do you want? So then maybe this is, or let me ask the question another way. Read my mind and tell me how I approach the workup of difficult to oxygenate patients. Okay, well, the PF ratio you can see there is 90, right? Sorry? Okay, so we can calculate the compliance from the information here as well, and it's low. Okay. CAT scan, okay, that would be good, but again, my unit, we usually start with an X-ray. So I think the chest, for me, when I see a patient who's in that difficult to oxygenate patient, the first question I want to ask that I ask myself is, what does the X-ray look like, right? Does it look like this, which would be not what I'm expecting necessarily, not the most common, but certainly can sometimes happen? Or does it look like this, where we've got, it's more like what we're typically expecting. When you think difficult to oxygenate patient, you think, oh, four-quadrant airspace disease, ARDS, I can fix that. But there's a significant minority of patients with, difficult to oxygenate, who you look at their chest X-ray and say, that's weird. I don't really see very much there. And the reason I make this distinction is because the approach here is going to be very different than the approach we'll take if the patient had the X-ray on the left. So how could this patient with these lungs that look so great be so hypoxemic? So maybe they had a PE, maybe it wasn't pneumonia, it was pulmonary embolism. Why else?
Analyzing error.
Sorry, an analyzing error. Okay, somebody didn't do the calibration correctly on the blood gas machine, but truly, the SATs are fine. and the blood gas machine is checked, you'd run them on another machine, the numbers are right. Yeah, so maybe it's shunting. That could be intracardiac shunting. Patient may have opened up, they may have a pre-existing cardiac shunt, or maybe they've opened up a PFO, which can happen in a significant proportion of patients with lung disease. And so all the extra oxygen in the world and all the lung recruitment or anything we're going to talk about next is never going to help that. It may just make it worse, right? So thinking about that, how would you confirm whether they had shunting like that? Yeah, an echo with some agitated with a bubble study. A little bit of blood and propofol works like a very nice contrast media, and with a touch of air. Okay. Any other reasons why why an X-ray might look like this and the patient could still be hypoxemic?
Extremely dry. I mean, very accompanied.
Yeah. So maybe this doesn't fit exactly with our case, but because we're a couple days into it. But on day one of mechanical ventilation, you see lots of patients, who've been treated for heart failure on the ward, or who've been at home and not feeling unwell and septic and not eating, and they're profoundly intravascular volume depleted. And there actually is a whole bunch of pneumonia there. You just can't see it because the lungs are artificially dry. And what might be clues to that if you're looking after this patient? Louder? Okay, so you could examine them globally, and maybe they look intravascularly depleted, their perfusion is poor, but often if they're in septic shock, that can be tricky, right? Because they could feel warm and well perfused, but still be somewhat intravascular volume depleted. What about stuff that you can do with a ventilator that might tell you that they're on the dry side?
Well, you can record and see.
Okay, what happens if this patient on the right here had this X-ray because they're really dry? I'm going to put the PEEP up from 10 to 15. What do you think is going to happen? Yeah, the blood pressure may go down and the oxygenation may get worse, right? The patient hasn't read their textbook in terms of, I thought PEEP was supposed to help oxygenation. But no, if the PEEP goes up and the oxygenation go down, to me, that's a sign that the patient's relatively intravascularly volume depleted. And why does the oxygenation go down? It's easy to understand how the blood pressure might go down. We decrease venous return, and therefore cardiac output falls. The oxygenation can get worse because we're over-distending the lung units that are actually open and that are actually participating in gas exchange, and that forces shunt to go to other areas of the lung that are collapsed and not experiencing the same airway pressure embarrassment, right? So those are all things that we would do quite differently if we did the chest X-ray and we saw the patient on the right. And most of the time, when we have a difficult oxygenation patient, the chest X-ray looks like that. You say, whoa, it's diffuse 4-quadrant airspace disease. No wonder they're hypoxemic. Some mixture of VQ mismatching and shunt because of alveoli that are full of stuff. It's always when you see a chest X-ray with airspace filling. There's only 4 things that cause that, right? It's always, life is good when you can reduce it to lists of 4 or fewer. So fluid, whether cardiogenic or non-cardiogenic pulmonary edema, pus, blood, inflammatory cells. Or if you're on the 10th floor of Toronto General, maybe protein, but only there. So generally only 4 things. And then the key thing here, this is the key slide. This is what you want to remember. This is what I use at the bedside to think about oxygenation issues with ARDS. The key thing is to recognize that that diffuse airspace disease that you saw on the chest X-ray, excuse me, is actually not diffuse. Most of the time, the CT scan looks more like this, where you have areas of relatively normal lung in the non-dependent regions, and areas of collapse and consolidation and atelectasis in the dependent regions, right? This is the idea that the lung is this wet sponge, or it's like a slinky. You hold it up at the top, it stretches open at the top, gets aerated, and the bottom sort of collapses and closes in on itself. And so we don't have time to go into this right now, but of the physiological causes of hypoxemia in ARDS, most of them are due to some combination of VQ mismatching and shunt, right? And shunt is just one extreme of VQ mismatching. So it's all due to VQ mismatching, essentially. Flow and gas exchange, flow and ventilation, blood flow and airflow are not coordinated well because we've got airflow going up here and we've got blood flow going back here with gravity, right? So the approach to this is relatively simple. If I've got VQ matching problems, let me do things that are going to try and pair them up better. So on the top, thinking about trying to improve blood flow to areas of the lung that are already receiving gas exchange. Here I might be giving fluid. This can be a little scary, but sometimes the right thing to do in a patient who's desaturated on 100% oxygen is give them 5 liters of fluid. If you're confident that it's not heart failure that's causing their problem, but in fact is ARDS and they're relatively underfilled. Here we may want to augment their cardiac output, avoid dynamic hyperinflation. We might also use molecule of the year from 1996, nitric oxide, right? As an inhaled thing. This is a selectively selective pulmonary vasodilator. Selective because it only works on the pulmonary circulation, and selectively selective because it's only going where the inhaled gas is going, so it's going to divert your blood flow where you want and give you better matching. And although studies of NO's kind of been maligned because it doesn't improve, it doesn't save lives in ARDS, but it very reliably improves oxygenation in the majority of patients. And so if your patient's actively dying of hypoxemia, this is a relatively easy thing that you can introduce to try and get the PO2 up into survivable levels. And proning is on the list here, but actually the major effect of proning is on the part below, as we'll talk about in a second. At the same time that we're doing this, we're trying to improve blood flow to one part of the lung. We're also trying to improve aeration and gas delivery to the other area of the lung, right? And here the strategy is about PEEP and recruitment maneuvers. What's the right level of PEEP to use? Easy question. And should we use recruitment maneuvers? Who still uses recruitment maneuvers? Who feels guilty about using recruitment maneuvers after the publication of the ART trial? Who still uses them anyway? Okay, all right. I think just as an aside, I still use recruitment maneuvers as well. I think the important lesson that the ART trial taught us is that aggressive lung recruitment can have hemodynamic consequences, right? And so I think probably we should be careful about very aggressive, very high lung recruitment maneuvers. But you have to take that in the context of all the other evidence about lung recruitment and higher PEEP, which generally have been shown to be safe and certainly effective in improving oxygenation. APRV, airway pressure release ventilation, sometimes can be used as a lung recruitment mode. Who likes using APRV in the room here? No? And when we talk about APRV, actually, unlike most other modes, when we say, oh, I'm using pressure support, everybody knows what you mean, right? When we use APRV, that could mean a whole number of different things. We could have American trauma surgeon APRV, which is very long T high, short T low, P low of 0, right? That's one extreme. Or we could use it as European APRV, which actually is just like IMV, right? Just looks like pressure control or IMV. Depending on how you set it up, it might be helpful in terms of improving oxygenation if you use it so that the mean airway pressure is higher, okay? Prone positioning, as Lorenzo talked about before, is a very effective way of improving oxygenation and recruiting the lung. because when the patient's lying on their back, and especially if you already have them sedated and paralyzed, positive pressure is going to push the chest out this way, right? The bed is behind them, the abdomen is down below pushing up. So it's only natural that the chest is going to expand outwards. And that's another reason why we have aeration in these non-dependent lung regions. When you put the patient prone, now suddenly, still their spine stops things from going backwards. The bed is now preventing the chest from going out. And so that actually forces the diaphragm downwards, and you get this recruitment of the basilar lung regions that previously were atelectatic and collapsed, and that improves oxygenation and has a number of other benefits in terms of distribution of forces within the lung. And then finally, HFO is another technique that one might use for oxygenation in a very severe patient who's dying of hypoxemia. Anybody use HFO here now? In the past, who used to use HFO? Lots of people. Okay. And now all oscillators are gathering dust because everybody feels guilty about breaking out the HFO. Well, I'll show you. Actually, I think that there are some new data to say that we shouldn't use HFO in patients with moderate ARDS. But in patients with very severe ARDS, there is some heterogeneity of treatment effect, i.e. HFO still looks like it's better than conventional ventilation when the patient's baseline oxygenation is very severe. That's most of what I wanted to say, but I'll show you a few more slides just to get into this a little bit. So in addition to that CT scan that I keep in my head, this is the other figure that I think of, and I'm trying to, at the same time as we're trying to save the patient's life from dying from hypoxemia, we're still trying to protect the lung as much as possible, right? And recognizing that we want to for sure avoid this zone of overdistension with every breath. And we probably also want to avoid having a huge zone of derecruitment and atelectasis, maybe because opening and closing might be harmful, but probably even more importantly, the more atelectasis you have, the higher your chances of having overdistension with every breath are. The smaller your baby lung and the smaller your safe window. So one of the things that we routinely do in a severe ARDS patient is to try and get up this volume pressure curve, take advantage of some hysteresis, open up the lung, and then be here on the deflation limb of the volume pressure curve, having better oxygenation and less lung stress and strain. We used to think we could do this. You remember the first Marcelo Amano paper that just said set PEEP 2 centimeters above the lower inflection point of the volume pressure curve, and back in the late 90s, we were all doing lots of super syringe volume pressure curves looking for the secret sweet spot. I think now we don't do that anymore, partially because we realize that the lower inflection point is not where the lung is open. It's where the lung starts to open, right? And you can see here there's continued recruitment all the way up the volume pressure curve until you get to the upper inflection point. Just to show you that these are mostly sustained inflation recruitment maneuver studies that are summed together here, that if you want to improve oxygenation, a recruitment maneuver, a 40 by 40 recruitment maneuver will generally yield good results, especially if you combine it with some higher PEEP afterwards. And how are we doing using higher PEEP? Seen some of these data already probably, but worldwide, we're not using very high levels of PEEP. Even in severe ARDS patients with a PF ratio less than 100, average of only 10. Now you say, that's the world. We're Canadians. We're better than that. Maybe not. So these are data that Eric Dewan helped put together as a follow-up from the Oscillate trial, where we just collected data on how we all were looking after severe ARDS patients. And you can see that 3/4 of patients had a PEEP of less than 15, despite developing refractory hypoxemia. And it's also interesting to see what other adjuncts folks were comfortable using. So different adjuncts were listed across the bottom here. according to the average FiO2 when the patient was at when they were initiated. So clinicians tended to reach for steroids, if you consider that an adjunct, relatively earlier. Little use of esophageal balloons or APRV in this population. Quite a fair amount of neuromuscular blockade, but usually when the patient was quite severely hypoxemic. Prone positioning, even in patients with refractory hypoxemia, which we define as a PO2 less than 60 on 100% oxygen, only fewer than 30% of these patients were in the prone position. And reaching for vasodilators and HFO when the patient was in extremis here. This is the data I wanted to show you about the HFO phenomenon. So this is a graph showing the effect of HFO versus conventional ventilation. When the odds ratio is above 1, conventional ventilation is better, HFO harmful. When it's below 1, HFO is better. And depending on what the patient's initial PF ratio was, you can see that there's a significant interaction here. So if the patient's PF ratio is below 100, if you want to be more conservative, below 61, where all of the 95% confidence interval is below the line, then HFO is actually better. So I think this sort of validates the clinical impression that many of us had when we first started using the oscillator, that for sure there were people's lives that we saved who were really hypoxemic and we put them on HFO and they got better. And then we started thinking, oh, the theory of HFO and preventing ventilator-induced lung injury, and it worked well in that patient who was really dying. Let's try it on people who are a little less sick. And that probably was not effective and counterbalanced by adverse effects on hemodynamics. But at least these data, I think, would make one feel good about trying HFO if you had that available to you and a patient was really hypoxemic and you after you'd already had them in the prone position. Okay. What about patients who look like this? They're actually very difficult to oxygenate. And here you might need to go for an ECMO cannula. The truth is, the X-rays only ever look like this after the ECMO cannula is already in, and we turn the airway pressure down to 10. But trying to oxygenate a patient who was this sick may be a challenge. And again, we have new data that say that this is probably a reasonable thing to do. So the questions that we often get are, who do we call for to put on ECMO? And I think looking at these inclusion criteria from the OLEAS trial just published a couple of weeks ago in the New England Journal are useful here. So severe ARDS with most of the patients in the trial had this criterion: a PF ratio less than 80 on at least 80% oxygen for at least 6 hours. After they've already been stabilized and had their PEEP turned up, and at least half of them were already in the prone position. Okay, so I think that's the general order of, if you're approaching a hypoxemic patient, the general order of it is initial hemodynamic resuscitation with fluids and make sure their cardiac output is okay, that they're sedated, paralyzed, then recruitment maneuver and PEEP titration, then prone position, then ECMO, if they're still presenting challenges. Just to show you that they got these patients into the trial very quickly, and almost 60% of them were in the prone position already. And although the p-value is not less than 0.05, some pretty positive results from this trial that when combined with the sort of underpowered nature of it and the high numbers of crossovers, for me at least, I think these are pretty compelling data that we should feel comfortable using VV ECMO in this group of patients, as I said, with a PF ratio less than 80 for 6 hours after resuscitation, after higher PEEP, after prone positioning. Questions, thoughts, comments?
Do you ever bypass that sequence and decide to go straight to proning based on PF ratio or clinical data?
So I would almost always, I think it's important to get the patient stabilized and resuscitated first, right? And because that that may solve a number of oxygenation problems. And then for me, it's much easier to manipulate PEEP before I go to prone positioning, because having the patient prone then commits me to deep sedation, maybe paralysis for the rest of that day and maybe longer. And if it's very early in the patient's course, you don't really know if they're going to be the type of patient who has, some patients have very bad hypoxemia, but 12 hours later, after you get them resuscitated and the PEEP's up to 12 or 14, suddenly they're much better and they don't need to be prone. So maybe, I never say never, but I would almost always go in that order. There are some patients who are really severely hypoxemic, who we skip the proning step and go straight to ECMO. But more often than not, we will try proning, especially unless there's a contraindication to do so. The patient's had major abdominal surgery or has something that we can't put them flat. But being severely hypoxemic or being on vasopressors is not a contraindication to trying prone positioning. Some people get nervous that, oh, sats are 88. I'm worried about turning them prone. Maybe they'll make them worse. Well, that may be true, but chances are it won't, and you can always put them back if it does.
How are you optimizing your PEEP level?
So this could be another whole hour-long discussion about what's the right PEEP. I think the right PEEP is, there's two questions in there. I want to set for a patient who has an X-ray that looked like that, the one on the left, I want generally higher. So I'm talking somewhere in the 14 to 20 kind of range. And then the exact level, you could do this either the simplest way to do this is just to use a PEEP FiO2 table. And again, I think you can feel still somewhat justified in doing that by, there's a paper from Gattinoni's group that shows, actually, if you want to your goal is to use higher levels of PEEP in people who are more recruitable, which makes sense to me, then a PEEP FiO2 table actually achieves that most of the time, and achieves it actually better than other fancier methods like using an esophageal balloon or the stress index or things like this. So I'll often start with that, and we'll sort of turn the PEEP up a little bit. And then if patient's still very hypoxemic and/or, which may be the case, or we're worried about peak, plateau pressures being a little elevated, then a recruitment maneuver, usually we'll do a 40 for 40 sustained inflation maneuver, and then a decremental PEEP trial with the patient paralyzed. And I just usually do this with the patient in pressure control, so that you can very simply just look at the tidal volume as a measure of compliance, and you can find the PEEP which has the best compliance. And usually, if you look at studies that have looked at different methods of setting PEEP, whether it's compliance or EIT or things, they generally work together, right? So you can find the place with the best compliance, and that'll also usually be the place with the best oxygenation.
Do you leave it at that level or slightly lower once you find this?
So try to find where the best compliance is, and then you always overshoot it, because you only know it's the best when you go down to the next one and it gets worse, right? So then you go back and re-recruit again and go back to the one that you thought was the best.
Do you look at the driving pressure or
Well, I would always try to use the lowest driving pressure that I can. And if you've had success with lung recruitment, you should see a reduction in driving pressure for the same tidal volume, because your compliance will change. Remember, we heard this morning that driving pressure is just tidal volume divided by compliance. So if either of those change, then your driving pressure is going to change. But the truth is, most of the data about driving pressure were derived from patients who already controlled the tidal volume. So in a setting where you've controlled the tidal volume, then driving pressure becomes very important, because that's like saying compliance is very important, right? But to say, oh, we only have to worry about the driving pressure, I don't think that's right.